Okay, good. Chat's working. Yay. Chat's good with everybody. Well, good evening, everyone. My name's Laurie Davin, and I'd like to welcome you to the NAFTA's 2022 webinar series. Tonight's topic is culture of safety for our patients and our team. Our speaker tonight is Jessica Sewell, and we also have Dr. Rochelle Lowe from Mars Veterinary Health, who is our sponsor tonight. So I would like to give a big thank you to Mars Veterinary Health. Everyone will be muted. So if you do have a question, please put your question in the Q&A, because if you put it in the chat, that's a live feed, so they do get lost, and we try to keep track of them, and there might be a large number of attendees tonight. So if there's a question you really want answered, Dr. Lowe is going to be watching the Q&A, so she'll be able to answer your question. It's 1 hour and it is being recorded. So now I would like to welcome Dr. Lowe to the presentation here tonight. Welcome, Dr. Lowe.
Great, thanks, Lori. Hey, everyone. So I'm Dr. Rochelle Lowe, and I work for Mars Veterinary Health. And my role is actually, I'm lucky to have a role in this whole area of quality and patient safety. Mars Veterinary Health is a group that kind of spans the globe. So we're in about 21 countries around the world. And I'm just lucky to kind of be in a role where, we get lots of different perspectives, especially lots of working with lots of different cultures. So I am very excited to introduce Jess Sewell tonight. So she's someone I've worked really closely with. Jess graduated from Gwinnett Tech College in Georgia with her associate's degree in technology, and then earned her bachelor's degree in veterinary technology from Florida's St. Petersburg College. She's currently a regional technician and assistant director at VCA Inc. And in 2021, Jess was selected to become the first veterinary technician to serve on the Georgia State Board of Vet Med. She also serves on the Georgia Vet Tech and Assistants Association as vice president, and was previously the president. And all of that is super impressive. The other big thing to know about Jess is that she is a huge Georgia Bulldog fan. So watch out on game day. So I'll go ahead and turn things over to Jess, and excited you guys are here to listen about patient safety culture.
Awesome. Thank you, Dr. Lowe. Hey, everybody. So we're going to talk about the culture of safety tonight. And actually, it was several years ago that I first heard about a culture of safety, and like, what does that mean? What does that look like? And the person I first taught me about this topic is Dr. Lowe. So we actually did this presentation together about a year ago. So it's nice to have her on tonight. Hopefully I make her proud. It's awesome working with her. So we'll get right into it. So let's see. All right, so tonight we're going to talk about, what is patient safety, why it's important. We're going to talk about how errors happen. To kind of describe, I want you to be able to describe and define a culture of safety in your own words, and use some safety tools that we have in PACE discussions. So we'll do that later. All right. So what is a medical error? It's otherwise known as patient safety event. So it's harm or potential harm caused by medical management, treatment, something else besides what's going on with the patient, the disease process, the injury. All right. The actual definition is the science of handling medical errors, preventing errors, and supporting patients and team members through adverse events. So, and that's a key here is, forget the team members. We'll come back to that, but in an adverse event, our coworkers are a big part of that. So medical errors, it's really complex. And we have to remember that no matter how much experience we have, no matter how many degrees we have, no matter our title, our role, we are all human. And that's true for all of us. So to make errors, that's just part of being human. So showing ourselves some grace and our team members some grace as well is key. So we have a lot of information about human medical errors. We don't really have that information quite yet for the veterinary world. We are working on it. It's coming. But if you look at patient safety in humans, 33.6 million admissions to US hospitals, 44,000 to 98,000 die in hospitals. People die in hospitals a year because of medical errors. And that's more than car accidents, breast cancer, AIDS. So that's quite alarming. Medical error is the third leading cause of death in humans in the US. So some just examples of medical errors that, they may be very basic, depending on where you work, what type of environment you work in, but a medical error is a medical error. So if we're talking about moving the decimal place, right? How often does that happen? I'm not a math magician, so I always double check my math. That decimal can get us. So 6 mils of ketamine, giving that to a cat as an induction agent. Cefazolin given epidurally. A patient coming in for a mass removal, we do a neuter, or we've heard of, in the most extreme cases, I have heard of wrong patients being euthanized or wrong legs being amputated. Those are some extreme cases, but it happens. A thermal burn from a warming device, patients discharged with the wrong insulin dose. So all of these are examples. Again, depending on where you work, they can be very basic, but most adverse incidents and errors are preventable. So first we have to ask, like, why do errors happen? And I think more importantly, it's good to start with what's our natural response when an error is made. And if we were face to face right now, I would be asking you guys, in your opinion, in your experiences, when an error happens, what is one of the very first thing that a lot of folks do? And it's to place blame. And this is not a culture of safety. It's the opposite of a culture of safety. So instead of blaming someone, instead of the whodunit, it's why. Why did this happen? How did this happen? Instead of who did it and who are we going to write up? Who are we going to fire? I think as it's human nature for all of us in leadership roles when we're baby leaders. I think that's it's human nature, right? To want to write someone up, blame them, and so we learn that this isn't the way. So don't focus on blame. It's how and why the errors happen. So actually heard this phrase. It was on a Mars online event, and it was someone was on there and they talked about a culture of safety and protocols, SOPs, actually not in the veterinary industry, but they said, blame the process, not the person. Blame the problem, not the person, because we'll learn that the problem is the process in these incidents. So this really resonated with me. It stuck with me. So remembering that when an error happens, chances are it's not the first time that it's happened, whether we know it or not. And if we don't correct the problem, the process, chances are it's going to happen again. So in other words, medical errors, it doesn't involve just one person. Typically, it doesn't involve a single isolated incident. It's usually a series. It's a snowball, a cascade. So there's two types of errors. There's active and latent errors. And active errors occur at the front line and we feel their effects almost immediately. So I'm thinking, for me as a technician, let's say I give some enrofloxacin, the syringe isn't labeled correctly, or I'm told it's flush. I don't know, I'm just totally pulling this off the top of my head. And let's say I just push the Baytril, the enrofloxacin, and the patient starts seizing. That would be a frontline operator error. That's an active error. Latent errors are, it's removed it would be removed from me, but the effects aren't felt right away. It's poor design or bad installation, bad maintenance, poorly structured organizations, poor structured protocols. So this is a cockpit of an airplane, obviously. And aviation is a very high risk field, as well as the automobile industry, nuclear engineering, and medicine. And I first heard about aviation and cultures of safety from Dr. Lowe, and it's fascinating to me. And we'll get into it in a minute, but it's very enlightening, and we have can learn a lot from them. It's quite fascinating. So we'll come back to that. So just using the example of aviation. So an active error, we talked about the injection, the Baytril, the enrofloxacin. Let's say active error is just a pilot crashes a plane. A latent error would be there's a malfunction on the plane. And so the pilot can't operate the plane. And so then he loses control and it crashes. So you see the difference there. So here's something we run into all the time, all day long. We have two very different drugs, but the labels look very similar. Especially even, right, those of you who are very experienced or you've been doing this a really long time, you're like, it's convenient, Serenia, those aren't the same drugs. Like what? But let's say you have someone who's new to the practice, maybe they're not familiar with these drugs, somebody who's new to the industry, or maybe you have somebody who's emergency critical care and they're really tired. These are similar labels, similar names of two different drugs, right? So what do? How do we keep errors from happening with these drugs being mixed up? So we adjust our protocol. We put fail safes in and tall man lettering. So if you ever look at like certified pharmacy type, I'm actually a certified pharmacy tech human, but tall man lettering, there's a whole lot of information on that, and it's just a fail safe, right, for preventing one more way for us to prevent errors. So 95% of errors are made by people like all of us on this call, right? We're really well trained. We're very conscientious. We're diligent. We are, we care about what we do. We're passionate about what we do. We want to take care of our patients. We want to do a great job. We have the best of intentions, but all too often we get caught up in faulty systems. And that's, so the problems, the processes, and that's where mistakes happen. 95%, that's where they come from. And the biggest obstacle to us putting prevention of errors in place is that punitive aspect. So we tend to, as humans, our first instinct is to punish people for making mistakes, and it shouldn't be punitive. It should be a learning opportunity and a chance for us to look at the problem, which is the process, not the person, and say, what's wrong with this process, and how are we going to fix it, and how are we going to prevent it from happening again? So through that way, you can use a systems-based approach. So the first thing you have to realize that all systems and processes can fail. And that's where it's really important for us to kind of dissect it, especially when an error occurs, dissect it and make changes so that it doesn't happen again, or it's less likely to happen again. So focus on finding those unsafe conditions and those cogs in our protocols, and correct them, ideally before injury occurs. Recognizing errors are most often it's not just a single person, it's not a single isolated incident, it's a series of incidences, and it's probably most likely not the first time it's happened. And again, if we don't fix it, it's going to happen again. We're all human, and any of us can make that mistake. So how do we find and correct the systems to prevent future error? So the Swiss cheese model, and again, this is something I learned from Dr. Lowe. So basically every layer of the Swiss cheese has holes in it. So each piece of cheese represents a different area. Maybe it's, like our team, our organization, our equipment, our protocols, our building design. And when all the holes align in a department, or some of the holes align in a department, that's when we have errors happen. That's when our patients are harmed. There's also the fishbone diagram. And we'll get into this. We'll actually kind of use this later to go through some cases, but each spine, similar to the Swiss cheese, piece of Swiss cheese, each spine on the fishbone represents a different area where errors can occur. So again, our equipment, our team, policies, processes. And just keep coming back to, we blame the process, we blame the problem. We don't blame the person. The problem isn't that our people are bad. The problem is that our systems need to be made safer. I actually came across this article today, and if you guys are interested in it, I put the link in, but it's obviously a human article, but a lot we can learn from them. So reducing medical errors. And so how do we do that? And they go through much, obviously it's very aligned with what's in this presentation. So a lot we can learn from them if you guys are interested in reading through that. But how do we reduce medical errors? So there's 3 big things to remember. First is, again, as a take-home message, it's we don't place blame. We're focusing on solutions and improving our protocols and our SOPs. It's not the whodunit, right? And by doing that, we start building a strong culture of safety for our patients. What we want is for people to feel comfortable coming forward and saying, oh, I don't know how to do this, or I'm unsure of how to do this. Can you help me? Or, hey, I made an error. Reporting that to us. Feeling comfortable. They want to discuss cases. They want to do a root cause analysis if an error is made, so that we can use that as a learning opportunity and we can adjust our protocol. So really building that trust and that safe space, and where mistakes are and errors are an opportunity for improvement and learning. So the third thing, we talked about earlier is supporting people going through adverse events. So no matter the adverse event, obviously for us, it's horrible when we lose a patient, right? That's like the ultimate. That's the worst. But no matter the adverse event, no matter how much they're involved in it, if we have to be supportive and show grace to our team members and to ourselves. So this is where, if we were face to face, now that we've kind of gone through a lot of this, tell me what your idea of a culture of safety looks like. If you didn't see the definition, you had to describe it. So when a team, so an organization, they share the same values, they believe the same way, the norms and procedures are related to safety. They're all on the same page, they're aligned. Team members are comfortable reporting errors, saying, oops, I messed up. Everybody's neutral. There's no judgment. It's not punitive. We're not placing the blame. People are willing to admit, hey, I'm human, I messed up. And people are willing to discuss cases and contribute to how to prevent future error. So human factors engineering in the automobile industry, which earlier we had the picture of the cockpit in the airplane. The automobile industry is an example of a high risk safety. So human factors engineering is the interrelationship between individuals at work, their equipment and their tools, and the environment where they live and work. So there's 3 domains. There's the physical, which is your workplace, the cognitive, which is your mental process, and the organizational. So all about communication and teamwork. So human error, what are factors that lead to human error? What are factors that are involved when an error happens? There's reliance on memory. So not writing things down, not entering things, medical record. And if you're like me, my memory is getting worse by the day as I age. So writing stuff down is super important. Interruptions and distractions, that is so huge in our day-to-day, even if it's, a CSR just coming up to you, if you're in the middle of, let's say, prepping a patient for surgery or whatever it may be, right? It seems like a really quick thing. Oh, I got to ask you a quick question, then I'll leave you alone. But yeah, it might be quick and it might be very easy, but it's still a distraction and it's an interruption in your process. Noise, inadequate lighting. I think of, the really loud dog that just won't stop barking, and it's like ear piercing. Fatigue and stress. I don't think there's probably not anyone on this call that can't identify with that, especially today. Boredom and fear. So threats to safe patient care practices, unfamiliarity with the task. Maybe it's training, or maybe it's that you have someone new to the practice and your way of doing things is different from how they've done it before. Inadequate time. It does really feel like we don't have enough time in our day. So maybe you feel rushed. Poor communication. This is huge, 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 huge. I know we focus a lot on communication. So this can be, between 2 individuals. This can be among within a department. This can be interdepartmental. So many departments. Very, very common, and really has a lot to do, contributes a lot to errors. Underestimation of risk and poorly designed workflow. So how can we modify conditions or protocols, processes that lead to error? So the first thing is safety relies on the design of safe systems, safe protocols, a safe process. The next thing is ask yourself or ask each other, where's the weak cog? Where in the system, what broke down? How did this happen? What led to the error happening? And it's, like we talked about earlier, it's probably more than one thing, right? So going back to kind of that supporting one another when a medical error happens. If you guys have ever had to make this phone call, again, if we were face to face, I would be asking you, how does this make you feel if you have to call a client about a medical error, or let's say you have to go to your supervisor, right? Because as humans, I think we know that our instinct is to blame, but I think also our other instinct is to be afraid to have that sort of knee-jerk reaction, like, oh, we get afraid to admit. So how do you guys feel when you've had to make that call, or you've had to go to your supervisor? Sick at your stomach, butterflies, maybe like for me, like it's almost like my blood pressure is going up. I just feel like the heat rise, butterflies, right? All of these things. And so when we're talking about being supportive and showing our teammates and ourselves grace, there's an effect, a phenomenon, a syndrome. I was actually reading more on it today. It's called the second victim effect. And so it's when we have a medical error and a patient suffers because of it, everyone involved becomes a second victim. And if there's not attention given to that, if we don't show them grace, if we don't support them, that can be lasting. There are stories of, veterinarians making a common mistake, right? We're human, we all do it. They make a mistake, and they can't, they leave the industry. They feel so bad, so defeated, they leave and they don't come back. And I'm sure that happens everywhere, I'm sure. So we really have to show each other grace and remember the no blame, right? We're focusing on the problem and the process. So there's something called RISE, and I've started becoming more familiar with this in the last couple of months. Resilience in stressful events. So it's a peer support group so that folks can support one another when they're going through these adverse events. So the World Health Organization did a study on surgical complications worldwide, and they found that 50% of them were avoidable. So this will be another time where if we are face to face, I'm gonna say, how do you think, how do you think that we can prevent them? And check off checklists, right? Pre-anesthetic checklists, drug dosages, surgical safety checklist, post-op checklist, recovery checkoff list. So we'll get more, and there's so many of these out there. And you can even, if your hospital or your practice or whatever your environment you're in, you can adapt these to make them work with your team and your procedures and the services that you offer. So this is fascinating to me. This back to the aviation. So I always thought, and Dr. Lowe actually spoke about this, and this is the first time I ever heard of it. I always thought that, I spend a lot of time in airports, lucky me. But I always thought that, the pilot and the co-pilot, or the pilot and the two pilots that fly the plane. I always thought that they just kind of they were best buddies and they trucked around together and they flew the same airplane. Maybe I'm naive, I guess, but that's not true. And most of the time when pilots fly together, they have never met each other. They don't even know each other. They've never crossed paths before in their life. And that's very impressive to me, because nowadays being in an airplane is one of the safer places you can be in, right? So, and it's how do they do that? How can two people, we work with the same people every day and we know each other really well, and we still have the off, miscommunications and the errors like we're talking about today. But how can two people who have never met before have records like this to where they can keep everybody safe and land the plane? And it's the checkoff lists. They have the same, they never deviate from their protocol. And it's actually very fascinating. And fly the airplane, it says on their checkoff list, fly the airplane. And it's because, you guys know, if we're doing the same thing every day, sometimes it becomes second nature. It's I think of when I'm driving somewhere and I kind of space out, or I'm thinking about something else and I end up where I'm supposed to go. And I'm well, I don't even remember, how did I get here? I don't remember passing this road. I don't remember passing that road. So, so that's why they put, because these guys do this all the time. They fly, they're always flying. So it's fascinating. I'm sure there's information on it, but look it up. It's very interesting. So we talked about the fishbone diagram earlier. So fishbone diagram is a tool for dissecting the different pieces that lead to an undesirable outcome. And it's for a root cause analysis. So we'll use it later to dissect some cases, but there's also, you can have safety investigation tools. And those are just kind of something to help you through a root cause analysis. So let's look at some cases. So the first case is Rusty. This happened on September 18th. And what happened? It was an error in reading or reproducing orders in a medical record. So Rusty came in for a right cranial cruciate ligament repair, but during prep, the team shaved his left hind limb. The error was caught by the LVT, the supervisor, and the surgeon was notified. So they then proceeded, they shaved the correct leg, the right leg, and they performed the cruciate repair. So luckily, the error was caught before the wrong limb was cut, but the patient still went home with naked legs, naked rear legs. So what are some procedural things that we could look at in this case? Is there a double check system? You know, like if we think about, like if I've ever been into the hospital, they're always, every time they check my name band, ask for my birthday, check the medical record, double check, triple check, and check again. Did they cross-check the medical record with the appointment schedule and the signed surgical consent form? And is the medical record organized in a way that everyone can, that it's clear what's going on? So equipment factors, are there any equipment factors to consider in this case? And remember, with each, going back to the fishbone, with each of these questions, it's a spine on that fishbone. So there were no, all right, going back and forth, there was nothing equipment related here. What about our team? So maybe people were distracted. Maybe people were trying to, you know, when you try to multitask too much, maybe people were stressed. Maybe they were all tired. Maybe there's a communication breakdown somewhere. Maybe the training is an issue. Maybe they're short-staffed. What about environmental factors? The caseload, maybe they've got more patients that day. Maybe somebody called out sick and they're short-staffed. Maybe we need to schedule differently. Maybe we have more people on the afternoon than in the busier earlier in the day when the surgeries happen. Maybe we need to move some of those people to the morning. And then again, that culture of safety. Did the team members, if they were feeling overwhelmed or they were stressed or they were unsure, do they feel comfortable asking for help or admitting that, hey, what's going on again? Am I doing this correctly? So prevention, what are 2 to 3 things? So this is like our action plan. So we've talked about it, we've done our root cause analysis. So what are 2 to 3 things that we're going to do to keep this from happening again? Let's implement a double check system. Let's use it. Let's get a pre-op checklist and use it for every surgical procedure, every patient, every procedure, every time. And let's make, when the CSRs check a patient in, let's have them highlight the procedure on the surgical consent form and have everybody, including the owner, check it and confirm it. And then we identify or appoint people, right? Medical director, technician supervisor, or the lead technician, the surgery team lead, and probably the CSR supervisor too, because this involves them in this particular situation. And then we have a follow-up date. So there's very clear action items and deadlines. Because how often do we talk about, a lot of times we talk about things and then, you know, later on down the road, a month later, we're talking about them again. So we don't want them to happen. We want that to happen in this situation. We want to make sure we have clear action items. This is an example of an anesthesia safety checklist. The World Health Organization one earlier, that was another one. And there's a lot of them. I'm sure all of you have a different one that you use. Second case is Rosie, Rosie the cat. So this adverse event was medication related. She received the wrong drug. So the verbal instructions, and that's key, verbal. The verbal instructions given by the doctor to the technicians and assistants, they wrote LRS at 12 mils an hour on a treatment sheet. And after discussing the patient, the insulin dose, the 12 mils of insulin was written on the treatment sheet. So people are confused here, or they're just writing things down incorrectly, right? So this error was caught by a staff member, and they brought it to the attention of the medical director and the tech supervisor. So what kind of outcome, this is kind of outcome is this? It's called a near miss. So while nothing happened to the patient, it very easily could have. So this is what's called a near miss. And you still consider near misses as an adverse event. Still, that should still be included in, if you do any kind of reporting, those near misses should be included in that. So what are some task procedural factors to consider here? Maybe there's no double check or sign off on the treatment sheet in place. Is there a protocol where if a doctor gives a dosage, a drug, that they repeat it back in the hospital? I know in tech school and in human pharmacy too, they, all the checks, the right dose, right time, right route, right drug, all repeating it back. And here, obviously, we mentioned that earlier, that the orders were verbal instead of in writing. So no equipment factors in this particular case. So what are some of the teamwork? Maybe there was too much multitasking. People were distracted. Maybe people were stressed. There was clearly a communication breakdown. And maybe it's training. And we say that we don't always know doses in our head, but we can look and say, whoa, that's not right. So luckily somebody here said, whoa, 12 mils of insulin, that's a lot. And they were able to catch that. So environmental factors, caseload, maybe they had a lot of patients and they were short staffed, again, staff scheduling. And then safety, are associates encouraged, do they feel comfortable repeating the drug information back to the doctor? So there's the 5 rights. I know for whatever reason, technicians and assistants are, if a doctor says something, they're oftentimes afraid to say, wait, what did you say? Or, hey, you're mumbling, can you speak up? They forget that doctors are human too. So really getting that culture going in your hospital, where either you automatically repeat the 5 rights back, or you feel comfortable saying, hey doc, like, speak up, I didn't hear you. Did you say 2 mils or 10? So when in doubt, always ask. So again, we're going to identify our 2 to 3 things. So let's avoid giving verbal orders. Let's make sure it's recorded, make sure it's written down. And then when we are putting the treatment sheet together, making sure that we're repeating that information back to the doctor. The point people here are going to be your medical director or your practice owner, whatever that looks like in your hospital, your technician or assistant supervisor, maybe a veterinary or a veterinary assistant supervisor. And then we have a clear follow-up date on that. This is the last case. So we have Sophie. She was in for a hematoma repair. Her pre-op exam was good. Her blood work and thoracic radiographs everything was good. So induced with midazolam, hydromorphone, and propofol. And it was found during the procedure that the pop-off valve was closed for 4 minutes. And luckily a technician noticed the bag was full and it was not moving. The patient was not breathing, but the heart rate, blood pressure were still within normal limits. So the team worked together. They obviously released the pop-off valve, manually ventilated for the patient. Sophie luckily made a full recovery and went home the following day. So what happened here? The pop-off valve was closed. Isoflurane wasn't adjusted. And actually after the incident, the vaporizer was serviced and it failed inspection. Some end-tidal CO2 wasn't being monitored, and there was no safety pop-off valve in place. There's a lot of different, I'm sure you guys have seen them. There's a lot of different ones out there now. Quick release pop-off valves where you press, you don't lefty-loosey, righty-tighty anymore. You press and release. And then if a certain amount of pressure is in the system, it automatically releases to prevent barotrauma. So what are some factors with the process to consider here? With the initial event, no one thought to decrease the inhalant. No emergency drugs were ready. Again, the pop-off valve was closed, and we weren't monitoring in title. Was the patient even connected to any anesthesia monitoring equipment? Some equipment factors here. Do we have a safety pop-off valve in place? I think we see where both are, sometimes see where both are in place, where you have a quick release pop-off valve. We have you still have that access to the lefty-loosey, righty-tighty, the traditional one. And so it may be newer people to the practice, or people who are, old habits die hard, people who aren't familiar with the quick release pop-off valve, although it's much friendlier on your hands. They just do what they're familiar with, and they open and close the lefty-loosey, righty-tighty pop-off valve. So is one of those in place? If so, maybe we need to block access to the lefty-loosey, righty-tighty, the traditional pop-off valve. Is there a double check system in place? And are we getting our equipment, getting maintenance on it like we should? Because the vaporizer in this situation wasn't calibrated. And was it checked pre-op? Did we do a leak test? Did we check our system? People factors, so our team. What's the coordination and the communication look like with the doctor and the team? Did anybody feel that anything was off? If they did, why didn't they speak up? Do they not feel comfortable? Do they feel, if they spoke up, they're like, oh, I'm not going to say anything. They know what they're doing. I'm going to feel dumb. I'm going to feel stupid. So what happened there? So 2 to 3 things we're going to do. We're going to get that safety pop-off valve installed. We're going to make sure we have, moving forward, emergency drug sheets for every patient every time. We're going to have those ready in case we need it. We can quickly draw them up. And we're going to start using an anesthetic machine checklist before every procedure. We're going to identify our point people, and then our follow-up date. So some helpful tools, we mentioned your anesthesia safety checklist, your anesthetic machine and equipment checkoff list, and you guys. So sometimes I get frustrated when we have a lot of technology and equipment at our disposal these days, and I think we all too often rely on the equipment instead of us. So we know that equipment can fail. So really trusting our gut if we feel like something is off, speaking up and saying something. Don't forget that you have a voice, use it. Always be professional and respectful, no matter what your title, no matter how much education you have. Show each other some grace. If you see something, say something. And if you see the need for a protocol or a procedure to be put into place, and that means in writing, that doesn't mean, like if I say, hey, so what's your, where's your protocol for this? Oh, well, this is what we do. Okay, well, where can I find that? Oh, people just know. They just know that's what we do. And no, it needs to be written. Anybody in the hospital or your building on your team should be able to go and look up the protocol for any given procedure. And feeling comfortable speaking up about SOPs or protocols that are outdated or that need tweaking. They should be living documents. So as our teams change, as our industry changes, as our the services that we offer change, we have to update our protocols. Again, we're all human. We all make mistakes. It doesn't matter our title. It doesn't matter how much experience we have, how long we've been doing this. We all make mistakes. Everybody is part of the veterinary healthcare team, and we should all work together instead of pushing against each other. Whether it be CSRs and technicians or technicians and doctors, we all are on the same team looking at the end of the day to accomplish the same thing. Technicians and assistants, you're an advocate for your patients, your team, yourself, and your profession. So don't forget that. And we should all be advocates for a culture of safety. So working together and showing each other grace and supporting one another to prevent adverse events, and focusing on adjusting our processes and our protocols instead of blaming each other. So what's the goal about having a strong culture of safety? It's to improve the safety of our patients and the well-being and support of our medical teams. So there's a lot of patient safety references out there. We already talked about the World Health Organization checklist manifesto. That is a huge one. And also if you look up aviation, there's going to be so much stuff, and I find it fascinating. And TED Talk, I mean, who doesn't love a good TED Talk? So you've got the fishbone, you've got the Swiss cheese model, checklists and more checklists. And so also thank you to Dr. Lowe, because I would say my passion and interest in culture of safety started with her years ago. And I'm very grateful to be able to work with her. And thank you guys for listening. My email address is up here. You're always welcome to email me. I don't care who you are, who you work for, what role you play, you're always welcome to contact me. So
That's a very cute puppy.
oh, so I just lost him. He was sorry to put a damper on the night. Yeah, and that's why I put him on here. I'm like, I want to see, this is Archer. I just lost him like 3 weeks ago. He was my last dog. So now I am just stuck with a bunch of cats, which is fine. It's fine.
Oh, he's so cute.
Isn't he? He's
Like,
precious.
yeah, I would like to thank you, Jessica. Great presentation. And also Dr. Lowe, thank you for sticking around and answering some of the questions. And again, Mars Veterinary Health, thank you for sponsoring tonight. Great presentation. If anybody has any questions, please throw them in a chat. Dr. Lowe was answering some of the questions for you, Jessica. There was just a few, but a lot of people were putting in a lot of good information into the chat for each other. So if you wanted to look through the chat, you can also read it, or I can send you the copy of the chat tomorrow that I'll get from Zoom.
That's great. And thank you, Robin. I appreciate that. She says, sorry for your loss. Thank you.
Yes, so sorry. So cute.
Isn't he though? He's precious. Smelly. He was smelly, but he's precious.
Yeah. Well, if anybody doesn't have any questions, again, I would like to thank everybody, and have a great rest of your evening, and have a great weekend for wherever you are, and take care, everybody.
Good night, everybody. Thank you.
Bye-bye.